Good morning, everyone. Thank you for joining us today for this lecture by someone who needs very little introduction, but who I'm going to introduce anyway. Dr. Maurice Druzin is Professor of Obstetrics and Gynecology at Stanford University School of Medicine in the Department of Obstetrics and Gynecology. He completed his medical school training at the University of Witwatersrand in Johannesburg, South Africa, and residency training in obstetrics and gynecology at the University of Colorado Medical Center affiliated hospitals. Following fellowship in maternal-fetal medicine at the University of Southern California, he was appointed chief of the Division of Maternal-Fetal Medicine and professor of obstetrics and gynecology at Cornell University Medical College from 1980 to 1991. In 1991, Dr. Druzin was appointed Professor of Obstetrics and Gynecology and Chief Division of Maternal-Fetal Medicine and Obstetrics at Stanford University and Lucile Packard Children's Hospital, a position he held for over 21 years until 2013. Dr. Druzin's research and clinical focus is on fetal assessment and medical complications of pregnancy. He served on the American College of Obstetrician and Gynecologists Hypertension and Pregnancy Task Force, which published national guidelines in 2013. He was also co-chair of the CMQCC task force, which produced the Hypertension Toolkit in 2014, and again served as co-chair on hypertensive disorders of pregnancy in 2021. He was a member of the California Maternal Quality Collaborative, which publishes nationally recognized toolkits on hemorrhage, preeclampsia, and venous thromboembolism. And he has served on the California Pregnancy Associated Mortality Review and on the California Pregnancy Mortality Surveillance System, which determines the causes of maternal mortality and recommends preventative strategies. As many of you know, Dr. Druzin will be retiring this January after an amazing career at Stanford, a career in which he oversaw the transformation of the obstetrical service from a small program with only a single full-time MFM faculty and a couple of general obstetricians who worked out of a one-room PDC and a shared clinic space with GYN-ONC and GYN. There were no fellowships in any of the specialties, and the residency program was on extremely uncertain footing. All this changed with Dr. Druzin's arrival. I can attest to that because I was actually a resident here starting the year before he joined. And there's a story about the first time we met at the end of my intern year, but I will leave that story to another event. Over the course of his career, Dr. Druzin touched all aspects of our educational program. He at one point became the residency program director. He launched the Maternal-Fetal Medicine Fellowship and eventually became its director, and held the position of vice chair of OBGYN. He has trained and mentored countless numbers of OBGYN residents, MFM fellows, and faculty, and he has cared for our sickest patients with profound dedication, relentless hours of work, and ironclad commitment. He leaves a legacy that will not be forgotten, and one that we will be recognizing and celebrating in the next few months. So there will be much more said about Dr. Druzin at these events. But for today, please join me in a warm welcome as he presents Maternal Mortality in the USA. How can we move the needle? Maury, it's all yours.
Thank you, Yasser, and appreciate all the kind words. A couple of quick acknowledgements. I just want to acknowledge my family, my wife and my children, our children, and of course our grandchild, for all of their support throughout my career and for making my life so fulfilled. I'd also like to thank Yasser and all of my colleagues in OBGYN, anesthesia, the whole Stanford ICU group, everybody who has supported our patients throughout this time and allowed us to provide such excellent care. Maternal mortality, of course, is a very profound event, and if a mother dies, the family usually disintegrates, particularly in the developing world where maternal mortality is a problem. Maternal mortality in the United States is among the highest in the developed world. And the question is, can we move the needle from empty to full, which means no maternal mortality. It would be nice if we could just fill up the gas tank and eliminate the problem. Unfortunately, moving the needle is more like the picture on the right, which is the classic silent movie, which is called Safety Last, where Harold Lloyd was sent out to change the clock. And it's a dangerous time for mothers, and it's a difficult task. This talk is dedicated to the women who've died while pregnant or giving birth, and our work in trying to end preventable maternal mortality. To start off with, we just need to talk a little bit about statistics. And one of the things that we're going to look at are two statistics. The one on the right is called the maternal mortality ratio, which is really a very crude measure of maternal mortality, comes from death certificates and goes up to 42 days post-pregnancy, which is 6 weeks. This is the way maternal mortality is defined around the country and around the world, and that's used to compare countries. And again, it is not an ideal measure because it's a little too crude. In California, we do the one on the left, which is the pregnancy-related mortality ratio. And this, a couple of key differences is that we go up to 1 year after pregnancy, and we use vital statistics and data files to identify and rigorously verify deaths. And then we look at whether or not the death was pregnancy-related. This is all reviewed by an expert committee and determination of ways to prevent maternal death. So when we talk about MMR, which is maternal mortality ratio, it's the crude one, and we'll also look at the more sophisticated one that I've just mentioned, which is much more accurate. The British have been leaders in maternal mortality throughout the ages, and they recognized that pregnancy is a dangerous time. The British also have kept very good records, particularly through the church records. And so we have some data going back to the 1700s about maternal mortality. And what I've done is converted the maternal mortality that was in the church records to what we look at today. Now, remember that the denominator is 100,000 live births. So fortunately, maternal mortality is still relatively rare because the denominator is 100,000 live births. But if you look at this table on the top there, it says 1700 to 1750. Maternal mortality ratio in Great Britain was about 1,000 per 100,000 live births. And in 2016 in the United States, it was more like 21.8, and in California, it was 5.9. So there's definitely been a trend downwards. But remember that number of 1,000. And again, in Britain, the four major causes of death, they called it the four horsemen of death, were puerperal pyrexia, which is infection, hemorrhage, we know what hemorrhage is, convulsions, which is essentially eclampsia, and illegal abortion. And of course, in our country today, with the Dobbs ruling, illegal abortion is going to become a problem again. This map of the world from 2015 looks at maternal mortality ratio, and the color scheme is that if the deeper the red, the higher the maternal mortality ratio, and the arrow is pointing to the maternal mortality ratio of greater than 1,000 per 100,000, which is the same as it was in Great Britain in the 1700s, and you can see that it's concentrated in sub-Saharan Africa. So the problem is still here today in 2015, a very similar maternal mortality ratio, the crude ratio, of course, than was in Britain in 1700. And going on to the leading causes of death, nothing has really changed. From WHO in 2019, leading causes of death were bleeding, infections, high blood pressure, which they called convulsions, complications from delivery, and unsafe abortion were the top 5. And updating up until 2022, the United States map, the lower number is the blue is the lowest number. So California is 10.5 per 100,000, up to a maternal mortality ratio of 41, which is in Tennessee. And you can see that the southern states here that have a highest maternal mortality ratio. And this is the United States, the current state of the United States maternal mortality ratio. Now, maternal mortality is one thing, but more common is severe maternal morbidity. And you can see that severe maternal morbidity is quite high if you look at the proportion of severe maternal morbidity, and if you go down to hemorrhage and preeclampsia, which are the two most preventable forms, most preventable causes of maternal death, you can see that maternal morbidity is high. And what is morbidity, maternal morbidity? Well, if you look at this chart here, which has got a population of 36 million in the United States from 1998 to 2006, and they're comparing patients who had eclampsia or preeclampsia to hypertension or hypertension to patients without preeclampsia, eclampsia, or hypertension. You can see that the maternal morbidity is very high. So acute renal failure, pulmonary edema, ARDS, cerebrovascular, which is stroke, ventilation, and mortality, the odds ratios are extremely high in these patients, particularly with severe preeclampsia and even with just chronic hypertension compared to patients without. So the burden is not only on mortality, but it's also on morbidity. And what's the problem? Well, the problem is that we have a change in health status. And if you look at this chart here from 2006, 2015, we have a huge increase in any severe maternal morbidity, as previously noted. We also have an increase in blood transfusion, which is one of the indicators of severe maternal morbidity. But even if you take out blood transfusions, you can see huge increases in maternal morbidity over the years. And the reasons are multiple, and we can't talk about that today very much, but we can see that the age is something. So maternal age greater than 35, morbidity increases dramatically, and mortality increases dramatically, particularly in patients over 40. We've had a lot increase in the cesarean section rate, which increases morbidity, and medical comorbid conditions have gone up dramatically as well. So, and of course, the obesity crisis, which we cannot ignore. So there are many, many reasons why we are seeing more morbidity and also more mortality. So California is an interesting place because we have a population of 40 million. We deliver about 500,000 babies a year, 1 out of every 8 United States births. We have over 200 hospitals and maternity services, and we have a very diverse population. And the California Maternal Quality Care Collaborative is a multi-stakeholder quality improvement collaborative which is attempting to address this problem. And as Yasser laid out, the Maternal Mortality Review Committee, which started in 2007, looks at all maternal deaths to determine, number one, is it pregnancy related? Again, the accuracy of whether or not it's pregnancy related is really important. As I'll show you, not every death that's reported as pregnancy related truly is. And of course, what the cause of death is and the preventability. So the mortality review started looking at on the top at the first 5 years, 2002, 2007. The review committee was put together in 2007. It is currently the Pregnancy Mortality Surveillance System, and it's a committee that a group of what are called experts, where we look at all the maternal deaths to determine pregnancy related or not, cause of death, preventability. And out of all of those deliberations have come all these toolkits looking at the 5 leading causes of maternal death and ways to address them. So the 2 major conditions where preventability is high are hemorrhage and preeclampsia. I will be focusing on preeclampsia for the rest of the talk, but if you look at the slide here, and there's data from North Carolina, California, and the United Kingdom. And the United Kingdom have been leaders in the efforts to reduce maternal mortality, as I mentioned before. But if you look at the preventability, you can see that many patients the deaths could have been avoided, particularly with hemorrhage and preeclampsia. Hemorrhage much higher than preeclampsia, but definitely no question that there's preventable deaths, and it's a matter of how do we address this to prevent these deaths, but not only the deaths, but also morbidity. Hemorrhage and preeclampsia are the most common preventable causes of maternal mortality and far and away the most common causes of maternal morbidity, and there's a lot of opportunities for improvement. The three deadly Ds that we found in most cases were denial, delay, and dismissal. Denial means that you're not making the diagnosis because you don't really want to deal with a very sick patient, and there's many normal pregnancy conditions that mimic the symptoms of preeclampsia, severe preeclampsia, and are dismissed, essentially. And patients complain that you don't listen to them, and we need to listen to our patients. We need to take them seriously, and we need to make the diagnosis and not delay in treatment. So this is one series of patients that we looked at, where we looked at the factors, provider factors contributing to these deaths. And the most common one was delayed response to clinical warning signs. And again, this is the denial delay thing, where the patient comes in with a headache, and we say, well, pregnant patients get more headaches, they have a little abdominal pain. Well, you have indigestion. A lot of patients have indigestion, and on and on and on, looking for reasons to not take on the fact that this patient may, in fact, have a problem. The next one is ineffective care, where the appropriate measures were not taken, and evidence-based measures have been around for a long time. We actually know how to take care of these problems. A misdiagnosis, and again, not being sure about what the diagnosis is. We need to make the diagnosis and put them into the category that's appropriate for that patient. And so there are opportunities for improvement to deal with the 3Ds: denial, delay, and dismissal. This is the cause of death, chance to alter outcome. Chance to alter outcome just means preventability. And I draw your attention to the fact that the blue is good to strong chance, which means had they implemented evidence-based approaches to this patient, the death or the morbidity probably would have, in this case, the death probably would have been prevented. High preventability, good to chance in preeclampsia and hemorrhage, less in cardiovascular disease, about 26%. And of course, cardiovascular disease is still the leading cause of maternal death. A venous thromboembolism, about 50%, but of course, amniotic fluid embolism, no good to strong chance because it's a sudden and catastrophic event. But it's really important to point out that there is a lot of opportunity to prevent these deaths. Now, I'm going to have to digress for a minute and talk about some basic pathophysiology so we can understand partly why we're not making the diagnosis appropriately all the time. The preeclampsia we think about as a disease that is high blood pressure. Well, it's true, high blood pressure is the sort of hallmark of the disease, but remember that the high blood pressure is an end organ response to what's an endothelial cell problem. Endothelial cells are the cells that line all of our blood vessels throughout our body. So it is a disease of the maternal endothelium. It begins in the placenta and ends in the blood vessels, and therefore it's a multi-system disorder because every one of our organs have got blood vessels. And we tend to forget the fact that it affects all the organs of the body, and it's not just high blood pressure, which is obviously a clinical hallmark. So every blood vessel, in our arterial side, our venous side, the inside of the vessels are lined with endothelial cells. And these endothelial cells are quite remarkable because an endothelial cell has multiple functions. And if you look at all the arrows, it's like mind-boggling about all of the different things that the endothelial cell controls. But let's just go down to the bottom line for the disease called hypertension, hypertensive disorders, preeclampsia. For a rapidly developing fetus and placenta, we need a lot of blood flowing into the fetal-placental unit. And to allow all that blood to flow, we need the blood vessels to be wide open. They need to be vasodilated. If you look down at the bottom here, the most important vasodilator factors are nitric oxide, which we all know about, and what's called prostacyclin. But there has to be a balance, so we have to balance the blood flow. We have to regulate the blood flow, and to do that, we also have to have some vasoconstricting factors that make the blood vessels a little narrower. And one of the major vasoconstrictors is thromboxane. Now, it turns out that in preeclampsia, for many, many reasons, the production of prostacyclin, the vasodilator, goes down, and the production of thromboxane, which is a vasoconstrictor, goes up. So the ratio is supposed to be more prostacyclin and less thromboxane, so we can maximize blood flow to the placenta, but in preeclampsia, it gets reversed. And interestingly enough, one of the reasons that baby aspirin works to prevent preeclampsia is it restores the thromboxane prostacyclin ratio in favor of prostacyclin, the vasodilator. It doesn't work all the time because there's many other factors, but I think that's a clinical pearl that we should remember, that the baby aspirin does that by reversing this ratio back to what it should be. So at the end of the day, what we have is a placenta that implants not ideally. The placenta then produces anti-angiogenic factors like S-FLT and S-Ang, which do not allow appropriate development of the blood vessels. And then you have this cascade of factors that cause more vasoconstriction, which means less blood flow, causing high blood pressure in the peripheral system, damaging the kidneys, causing protein in the urine, and damaging other organs like the liver and the brain. So it's a placental disease with starts in the placenta, ends in the endothelium, but affects every single organ of the body. Now, let's go back to our healthcare provider factors contributing to these maternal deaths, and let's just talk a minute about misdiagnosis. We have to make the diagnosis correctly when a patient comes in, presents themselves to us. And we need to know the definitions of the different conditions. And put it simply, there's not a lot of different conditions. So let's start with chronic hypertension. These are patients who have pre-existing hypertension, 140/90 or 90 or greater. So it's not 140 and 90, it's 140 or 90. So it's either systolic of 140 or diastolic of 90 or greater. And these are patients who have that blood pressure prior to 20 weeks of gestation. After 20 weeks, we call it gestational hypertension. If you add the most common end organ that's damaged, the kidney, and you add proteinuria, you now have classic preeclampsia, which is hypertension, 140/90, plus proteinuria. And that's without severe features. And those are the major diagnostic criteria. Now, chronic hypertension has a high chance, patients with chronic hypertension have a high risk of developing superimposed preeclampsia, which can be challenging because is this just the chronic hypertension getting worse, or is this truly the onset of preeclampsia in a pregnant woman who presents with high blood pressure? The other part of the definition that is important is to remember the blood pressures of 160 systolic and or 110 diastolic, because these are the danger levels, and these are the blood pressures that lead to the most common cause of death, which is stroke. So remember these numbers. It's 140 or 90, 160, 110, and the difference is severe gestational hypertension is a risk factor and is also a treatment trigger. As soon as you have a blood pressure of 160 to 110 or greater, we have to call that severe gestational hypertension. And if the patient has any other end organ involvement like proteinuria or any other organ, we now call it preeclampsia with severe features. So preeclampsia with severe features is either based on blood pressure alone or blood pressure plus end organ involvement, But severe gestational hypertension, which means the blood pressure alone, without end organ involvement, is still an obstetrical emergency and needs immediate attention. So no matter what you call it, the 160 or 110 is a trigger for intervention. HELP syndrome, which is one of the things that we talk about, is a subset of severe preeclampsia, which involves hemolysis, elevated liver enzymes, and low platelets. And remember, the H of HELP is hemolysis, not hypertension, because many patients with HELP syndrome do not have severe gestational hypertension. So this is another end organ involvement issue here where it affects the blood system, hemolysis, elevated liver enzymes, the liver, and actually drops the platelets as well. And that's the classic HELP syndrome. These are the severe features. We've already spoken about it, but I want to bring your attention to this 4 hours apart issue, which is in the definition of systolic pressures of 160 or 110 or greater, at least 4 hours apart. But this, in parentheses, is the most important point here. Unless antihypertensive therapy is initiated before this time. This means if somebody comes in with 160 over 110, you wait 15 minutes and repeat it. If it's still 160 or 110, they need to be treated. And as soon as they are treated, then you're done. You have preeclampsia with severe features, and you have to go down that treatment pathway. You do not wait another 4 hours while they have these blood pressures of 160 or 110 or greater. And these are the other criteria for preeclampsia with severe features, which involves the end organs, the important end organs. And finally, the most severe form of this disease is eclampsia, which is new onset seizures. These seizures are usually grand mal seizures, tonic-clonic seizures, the classic tonic-clonic seizures, but they may be focal or multifocal as well. And of course, you have to rule out other causes of seizures, such as epilepsy, drug use. But if a pregnant patient walks in and has a seizure, you have to assume that it's eclampsia until proven otherwise and put them on that treatment pathway because we know how to treat them and it's very effective. Fortunately, it's not all that common in the United States, about 1 in 1,000. But the mortality from an episode of eclampsia ranges from about 1%, so 1 out of every 100 patients who has an eclamptic seizure is going to die in the developed world, but about up to 15% in the developing world. So deaths from eclampsia are much more common in the developing world, and we need to be aware of that. And the WHO has recognized that, and we'll talk about that in a minute a little bit. So if you look at the spectrum of preeclampsia, what we call the deadly triad, which is preeclampsia with severe features, eclampsia or HELP syndrome, those are the precursors to these adverse outcomes. And remember, it's not just the mother, it's also the fetus that suffers from this disease. So abruptio placenta, renal failure, this is multi-system disorder, remember, so the kidneys are involved, subcapsular hepatic hematoma, the liver, preterm delivery. In California, about 25 to 30% of preterm births are as a result of the mother having to be delivered because of preeclampsia or eclampsia. So this disease has a profound effect not only on maternal health, but certainly on fetal and neonatal health, and contributes hugely to the burden of prematurity around the country and around the world. Remember that patients who've had a preeclampsia in a previous pregnancy has a high risk of recurrent preeclampsia. And we also now know that patients who've had preeclampsia have much earlier onset of cardiovascular disease. So oftentimes patients who've had preeclampsia with severe features, there's a study out of Europe, which showed patients developing cardiovascular disease, heart attack, stroke, severe hypertension as in their early 50s, which is unusual, of course, for patients, females, to develop cardiovascular disease that early. But preeclampsia in a previous pregnancy is a marker for some type of vascular problem, which will turn up in the future earlier than expected. Now, what causes maternal mortality? And again, in the United States here, you can see that 90% of patients who died of preeclampsia or eclampsia died of hemorrhage, hemorrhagic stroke. The other causes of death, much, much less. Hemorrhagic stroke is the leading cause of maternal death. And in the survey, in the first series of patients we looked at in California, similarly, most of the patients died of hemorrhagic stroke. So now, what can we do about this? This talk is to give us some hope, to give us some direction for the future. So it's not that complicated. It's not rocket science, which we know is supposed to be very complicated. You have to be really smart to be a rocket scientist or a neurosurgeon. It's neither of those. It's pretty straightforward. There's only 4 things to start with in the classification. You have to classify the patient appropriately. Do they have chronic hypertension? Do they have preeclampsia? Do they have superimposed preeclampsia? Or do they just have gestational hypertension? Now, just having gestational hypertension has been, for many years, thought to be sort of a more benign form of the disease, but we have to be very careful because gestational hypertension, particularly if it is in a severe form, has the same potential poor outcomes as any of these other classifications. So the first thing we have to do is put the patient in the correct category. There's only 4 of them. The second thing is management. And again, it's only 4 things. Number 1, blood pressure control. That's the key. Controlling blood pressure is the key to preventing stroke, which is the leading cause of death in preeclampsia. Number 2, seizure prevention. We have very effective forms of seizure prevention, and I'm going to ask the audience now for a quick survey. If a patient walks in with severe gestational hypertension or preeclampsia with severe features based on blood pressure, what's the priority? Should you control the blood pressure first or give them the magnesium sulfate to prevent the seizure first? So if you could all just in the chat put a 1 for blood pressure control or a 2 for seizure prevention, I'm going to have Dakeen count up the audience response to what should you do first. Dakeen, are people putting it in the chat? I can't
Yes,
see.
they are. And so far we have, everybody says number 1.
Okay, well, great. That is correct. The first thing you need to do is control the blood pressure because that is the immediate acute emergency. In the ACOG practice bulletins and committee opinions, they call blood pressures of 160 or 110 or greater an acute obstetrical emergency. And the recommendation is to treat them as soon as possible. The standard is to treat them within 60 minutes, which is a long time. We obviously should strive to treat them much earlier, within 30 minutes if possible, but the current ACOG standard is still within 60 minutes, although they do say that you should try and treat them much earlier than that. So number 1 is blood pressure control, and then number 2 would be seizure prevention. And then again, moving down this simple only 4 thing pathway, the next is delivery. So because preeclampsia is a disease of the placenta, you have to remove the source of the disease, which is the placenta, and removing the placenta obviously requires us to remove the fetus, which requires delivery. And we know very clearly with very good data that if the patient has preeclampsia with severe features that requires intervention, we need to deliver them at 34 weeks because if you delay patients with preeclampsia with severe features, if you delay, you're just going to make things worse. So 34 weeks with severe features and then 37 weeks without severe features. And there's been a lot of controversy about the 37-week rule because if the patient is stable and they have preeclampsia without severe features, why not keep waiting? There's still some room for debate on that one, but the HYPERTAT trials in Europe and in Holland showed that if you go beyond 37 weeks, the incidence of severe hypertension goes up quite dramatically, up to about 40%. So at this point, the guidelines still recommend 34 weeks with preeclampsia with severe features and 37 without severe features. And very important, and something that's always been sort of missed and ignored, is postpartum. Many of our patients who die postpartum, in some series up to half. And that is important to recognize that delivery is the most important intervention towards cure, but it doesn't cure the disease right away because you've got this endothelial cell damage from the disease that needs to heal. And so that those endothelial cells are still causing hypertension postpartum for up to a week, up to 6 weeks, actually. And so what ACOG is now calling the fourth trimester, which is postpartum, is really a critical time for us to be aware of the fact that that is still a dangerous time for patients who've had preeclampsia. And again, pointing to the United Kingdom, they recognize the importance of treating the blood pressure earlier than we did because although we focused on that some, they really made concerted efforts to treat the blood pressure and decrease the maternal mortality in the United Kingdom from stroke. And so that is the most important intervention. And thank you to everybody for putting that down as number one. And in our own state, our own Dr. Amy Judy wrote this really classic paper doing a deep dive into maternal mortality from the California database, looking at hypertension, preeclampsia-related mortality, and stroke in California. And what she identified was that there was a good to strong chance to alter outcome in almost 70% of patients. The usual suspects, delayed response to clinical warning signs in most of the patients, ineffective treatment in 3/4 of the patients. So instead of treating the blood pressure, everybody is running around trying to get the MAG mixed and forgetting about the blood pressure. Stroke is the major cause of maternal mortality. All of these patients in this series from California had severe elevations of systolic blood pressures. So that was the key issue. In the past, up until about 2005, 10, we focused on the diastolic blood pressure until James Martin and his group down in Mississippi pointed out that actually most patients who had a stroke and either stroke and died or stroke and survived had systolic elevations of blood pressure of 160 or greater. It took us a while to sort of put that into the algorithm so that we now know we need to treat the systolic pressure. And antihypertensive treatment was not implemented timely in the majority of cases. So there's lots of room for improvement. And again, pointing out that in Amy Judy's, the series that she looked at, 46% of the strokes occurred postpartum. So you're not out of the woods when you deliver this patient. That's the most important intervention, but you still have to keep very close watch on these patients. 12 occurred among the postpartum strokes, 12 occurred in the first 3 days within 72 hours, and 3 more than 72 hours. So the peak time is sort of that 3 days postpartum. You've got to focus on the blood pressure. You've got to treat the blood pressure and not just send them home if their blood pressures are still high. We have very effective treatments for blood pressure now. We have labetalol, hydralazine, and nifedipine. For a long time, it was just labetalol and hydralazine, and so you had to get an IV in. In many of these patients, it would be difficult to get the IV in. And then the nifedipine, oral nifedipine, got approved as a first-line drug, and that is a really great advance because you can just pop a nifedipine in, not the sublingual, just the regular nifedipine, 10 milligrams, and that can have an immediate effect. So you don't have to wait for the IV to be placed and so on. So this is important that we have very effective treatments that can be implemented quickly in a patient who presents with severe preeclampsia or severe hypertension. And then talking about seizure prevention, we know that it is indicated for patients who have a seizure, eclampsia, to prevent the next seizure, and it's indicated for patients with preeclampsia with severe features, although preeclampsia without severe features, it's a little controversial, but ACOG has made the statement that for preeclampsia without severe features, magnesium sulfate need not be administered universally. So they are not recommending that everybody get magnesium if they don't have preeclampsia with severe features. When I was training, we didn't make a distinction. If you had preeclampsia, you got MAG, but of course, MAG has some side effects as well. And the bottom line is the number needed to treat. 63 for patients with severe features, so obviously you're going to be treating them, and about 109 for patients without severe features. So you have to always put that sort of risk-benefit ratio in. But remember that patients with preeclampsia without severe features can also have a seizure. And the WHO recommends treatment of everybody because of those mortality data in the developing world, where the mortality rate can go up to 15%. So you can take a chance that this patient's going to have a seizure because of the high risk of mortality. So WHO recommends MAG for all patients with preeclampsia. And again, talking about the delivery, we've already spoken about that. You need to deliver them to cure the disease, but even though it's the most important therapeutic intervention towards cure, but the residual damage persists in the postpartum period up to 6 weeks. So you need early follow-up for all patients with preeclampsia. Eclampsia within the 3 to 7 days, because that 3-day mark from Amy Judy's paper was a dangerous time, and certainly within a week to 14 days if no medication was used. And again, one of the things that we've done in our toolkits is educate the emergency room. We actually had emergency room doctors on our task force because so many of our patients postpartum turn up to the emergency room, and of course, in the regular adult population, a 160 over 110, well, they've got chronic hypertension. It's not an emergency. And the sensitivity towards our patients in the emergency room was not there. So we have a whole section in the toolkits on the emergency room, and our emergency room consult from Kaiser did an incredible job of putting together signs that are up in the emergency room that says, if you are pregnant or have recently been pregnant, come to the front of the line. That way, we can prioritize patients who are postpartum, who have preeclampsia or hypertension, and get the obstetrical service involved and make sure that you're not missing a patient who still has residual preeclampsia, even though they are postpartum. So this is a critical point, and we've tried to address that in the toolkit. Now, talking about all of these interventions, is there a way of measuring whether these things work? And the Preeclampsia Collaborative was from the first toolkit, looking at the outcome measures, severe morbidity, and process measures, whether or not we treated these patients in a timely fashion. This was looking at if a patient presents, do they get diagnosed correctly? Do they get the correct treatment? And what are the outcomes? There's always been a concern about acute treatment of hypertension, that we would drop the blood pressure too low, affect placental perfusion, and therefore affect the fetus. And in the follow-up data, that did not happen. So we should not be withholding antihypertensive treatment because we're concerned about the fetus. It is very rare to have any effect on the placenta. You can drop the blood pressure that low. Sometimes you could, but very rarely. So when we looked at our outcome measures, again, the same theme came out. 17% of patients were not treated with antihypertensive medication, and the most common reason for not treating was that magnesium sulfate was started instead. So there's a misperception that magnesium sulfate actually is an antihypertensive medication. It is not. So we've made the statement very clearly. Magnesium is a seizure prevention. Antihypertensive medications are labetalol, hydralazine, nifedipine. And starting magnesium does not X out the fact that you have to start them on antihypertensive medication. Now, Larry Shields was one of my co-PIs on both of our toolkits, as well as Nancy Peterson, who's a clinical nurse specialist from Santa Cruz, and I wanted to acknowledge those two people as being incredible partners over the last many years, putting together all of these toolkits. Larry is, I don't know if he's retired yet, but he was the Chief Safety Officer for Dignity Health, which has multiple hospitals across many states. And they had a total of about 60,000 deliveries. I think it was 60,000 deliveries a year. And he implemented a bundle, very simple bundle, to treat the patients, the blood pressure, give them magnesium, and early postpartum follow-up. And he put this bundle in, and all the institutions he was in charge of followed these bundles. And you can see that just having a physician champion like him and putting together a simple bundle, they have pretty good results. So the 3-element bundle compliance, MAG, blood pressure, postpartum follow-up, started at 50%, went up to almost 90%. Magnesium sulfate, appropriately administered, went up to 96%, and appropriate hypertensive treatment went up from 56 to almost 80%. The overall morbidity went down. And so finally, I just want to talk about what is the data in California in terms of all of these interventions and effects on maternal mortality. I'm going to be looking at different periods of time, so just bear with me, but I want to give you the theme of the development over the years up until the most recent time. So this is 2008, 2016. And remember that we were looking now not just at the MMR, the maternal mortality ratio, but the PRMR, the one where we have a patient who dies, we look at all of the data, it comes to the committee, and we look at whether or not it's pregnancy associated or not. And in this particular cohort of 752 patients of maternal deaths from 2008, 2016, our committee determined that 608, which is about 80% of them, were pregnancy related. But notice that there were 135 that we determined were not pregnancy related. So that's why it's so important to get accurate data, is to have a review of the death certificates, which the maternal mortality ratio, unfortunately, is just death certificates. So it's a good start, but it's certainly not accurate enough. And this is the MMR and this is the PRMR. This is the most accurate measure. So let's look at maternal mortality ratios in the United States and California. And you can see that this is from up until 2016, going up in the United States to 22, just about 22, and went down in California to 5.9, the lowest in the United States. But if you go to the more accurate measure of PRMR, this is MMR, it's higher, it's double in California, and of course, it's still higher in the United States. So any way you look at it, and PRMR is up to a year, and this is PRMR up to 6 weeks, but this is the old ratio. A few things that stand out, and we know, and we really need to address that, is the fact that there is a disparity, a black-white disparity, which is quite alarming, that the Black population has a much higher maternal mortality ratio compared to any other population. We know that that's across the country and across the state. Looking at the causes of death, the leading causes again are cardiac disease, sepsis, hemorrhage, hypertension disorders, and thromboembolism. In early times, 2002, 2007, 16% died of hypertensive disorders of pregnancy. In this cohort, 2008 to 2016, it was down to 13%. Not really statistically significant, but clinically significant. Again, summarizing this, once the committee reviewed this, 608 of the over 700 patients were pregnancy-related. There was a spike in pregnancy-related deaths, and we all forgot about the 2009 pandemic, which was the H1N1. So there are spikes, and you'll see the same thing happen with COVID. The 5 leading causes of death I've mentioned before. Remember, 18% occurred while pregnant. The rest of them occurred after delivery. Almost half were within 6 days of childbirth or the end of pregnancy. That's why it's so important for us to remember that the 4th trimester is an important time for morbidity and mortality. The patients in this cohort were older, they were more obese, they were they lived in the least advantaged communities, which means that their socioeconomic status was not very good, and they had more than twice the mortality ratio for women living in more advantaged communities, and it varied by geographic region as well. The racial ethnic disparities remained and widened, particularly for Black women. So that is something that is really problematic. And Black women were overrepresented in almost all the cases. And interestingly, in terms of suicide and homicide, suicide ratios were stable, and women who were pregnant in the year prior to death were less likely to die by suicide, but more likely to die by homicide. Of course, these are all social factors, demographic factors, but of course, it is an important thing to observe. And now we're moving forward to more recent times and looking at the data from 2011 to 2019. And again, these colors represent the black ratio over here in the red, but you can see that the pregnancy-related mortality ratio remains quite profound all the way up to 2019. And even though California's pregnancy-related mortality ratio was lower, is lower than 2018, it's consistently lower than the United States, but we need to continue to work on this. Cardiovascular disease continued to be the leading cause of pregnancy deaths, followed by hemorrhage, sepsis, or infection. For the first time in this last group, up to 2019, the rate of pregnancy-related deaths from hypertensive disorders significantly decreased from the previous years. So that was a bit of a success story. And for the first time ever, hypertensive disorders are no longer among the top 5 leading causes of pregnancy-related deaths in California. And this graph, so hypertension is this little pink or red column here, and this is 2011, 2013, went down here, and this most recent one was a significant decline in deaths from hypertension, 75% reduction over 3 years. So there is hope that if we implement appropriate measures, we can make a difference. We can move the needle. This is the most recent mortality rates in the United States. And you can see that in 2021, there was an absolute huge spike, but most of it was from COVID. And again, COVID deaths in pregnancy are largely preventable, and we know that most of the patients who died were unvaccinated. So with our recent change in leadership, we need to be very vigilant about the fact that vaccines are going to be under attack again. So to conclude, what can we do? Can we move the needle? Well, hope springs eternal in the human breast, says Alexander Pope. It is human nature to find fresh cause for optimism. And we know that people are always thinking that they'll keep on hoping. So, for example, you go and buy a lottery ticket thinking that you're going to hit the lottery. Good luck. So, but what can we really do? Let's work towards eliminating disparities in healthcare, and the CMQCC has put together the Birth Equity Collaborative. We need to improve baseline health status. We need to decrease substance abuse. We also need to address things like anemia, and our own Dr. Iro Igbinosa has been working on that to address anemia in pregnancy, which has been underappreciated as a significant contributor to maternal morbidity and also mortality. We need to address food deserts. A food desert is an urban area where it's difficult to buy fresh quality good food. We need to change the desert to an oasis. There's been a lot of talk about what kind of a diet is appropriate for pregnancy, and the DASH diet, which is used for hypertension, also known as the Mediterranean diet, has been demonstrated to be a very good diet for management of patients who are pregnant, and particularly for prevention of preeclampsia. We also need to look at chronic hypertension in the general population and maybe treat lower levels of blood pressure as recommended by the American College of Cardiology and American Heart Association. So that is something that we can do as well. And when we talk about hypertensive disorders of pregnancy, we know that low-dose aspirin can prevent a recurrent preeclampsia. You may want to implement the DASH diet, which has got some data about prevention of preeclampsia. And we now know that we need to be more aggressive in treating chronic hypertension from the CHAP trial that Dr. El-Sayed was one of the co-authors on that one that was published in the New England Journal in 2022. So there are lots of things that are going on, but there's a lot of simple interventions now that are easily done by clinicians in general, following the toolkit recommendations and looking at all of these things that are easily implementable. What about treatment of hypertension in a timely fashion? Well, it can be done, and the group from Illinois did this study where they showed that if you use the ACO criteria of treatment within 60 minutes, they showed that once you made that decision, and you have to have a physician champion to do that, the goal was to treat 80% of women within 60 minutes. They achieved that goal. And so these things can happen if you put your mind to it and you have a physician champion and a physician and healthcare champion, nursing, all of the people who are involved in healthcare, you can do it. And they showed that they decreased in Illinois severe maternal morbidity dramatically, 41% reduction, by just implementing a program to get the blood pressure down. And a paper from Cedars-Sinai looking at whether they could treat severe range blood pressures within 30 minutes. So that's an even tighter guideline. And here's some data here. They looked at the group that had severe acute peripartum hypertension, and they looked at the group that had no severe acute peripartum hypertension. And unsurprisingly, the patients who had severe acute peripartum hypertension were older, more obese, lower socioeconomic status. Obviously, there was a predominance of Black patients as well. They were nulliparous and they had chronic hypertension. So this is the typical group that's going to develop preeclampsia. And then they made a concerted effort to treat the acute hypertension within 30 minutes, and they were successful, and there was no difference in there was no racial disparity here. So you need, if you have guidelines, you need to apply them equally to everybody, and you can make a difference. They had patients treated within 30 minutes in well over 90% of patients, and there was no statistical difference between whites, blacks, Asians, and Latinx. And so if you put your mind to it, you can implement these evidence-based successful measures to decrease maternal mortality. Again, there's cardiovascular disease toolkit. We have a sepsis toolkit that our own Ron Gibbs was leading. And we know that vaccines are very, very important in managing pregnant patients and decreasing the risk of death from sepsis. And lowering the cesarean section rate has been approached. We need to continue to work on postpartum hemorrhage, of course, because that's the other leading cause of death, which is amenable to intervention, but it's been difficult. And remember the fourth trimester, the postpartum care. And so thank you, everybody, for listening. And I'm happy to take some questions. I think we're just about out of time, but Dakeen, if you could take a look at the chat and tell me if we have any questions.
Maury, thank you so much for this wonderful overview and history. We do have some questions in the QA and one comment and a question in the chat, but for the Q&A, is there an explanation for a dramatic increase in postpartum preeclampsia since start of COVID? Olga Lvova is asking that question.
I'm not sure about the increase, and I'm not sure whether it's related to COVID. We do know that COVID does cause an autoimmune inflammatory response, and it's been shown that antiphospholipid antibodies are one of the leading causes of death in production of antiphospholipid antibodies and subsequent embolism are among the leading causes of death related to COVID. So I'm not sure if that's related to the postpartum preeclampsia at all. I don't know the answer to that.
And another question from Ed Cohen. Is there a clinical difference between the patient whose baseline systolic is 100 and goes to 134 and the patient whose baseline is 120 and goes to 140?
That's a good question, Ed. And the original, thinking about 2000, we still had the criteria for preeclampsia of a 30 systolic or 15 diastolic rise over baseline. That would qualify for gestational hypertension. Unfortunately, the positive predictive value was very low. It's about 50%. So those criteria, the 30 systolic rise or 15 diastolic rise to diagnose gestational hypertension, was taken out of the guidelines. I think clinically we should still be looking at that because it is not normal for a patient to have that increase, even though they don't reach the absolute number of 140. So the relative rise of blood pressure, I think, is clinically significant, although ACOG took that out of the guidelines as a criteria for gestational hypertension.
The next question is from an anonymous attendee. Do you think there's a time in the future where we will start PO antihypertensives on patients before they, quote, declare themselves, unquote, with severe range blood pressures or end organ damage to prevent morbidity? For example, starting PO labetalol on someone with non-severe gestational hypertension.
Yeah, I think so. And I think given the trend towards more aggressive treatment of hypertension in the non-pregnant population and also the data from the CHAPS trial, I think we're becoming more sensitive to the fact that we should be intervening maybe a little earlier. I mean, the CHAPS trial was pretty definitive in that. And so I think that in the future, we'll probably be more aggressive in treating chronic hypertension.
Yeah, sir, you're on mute.
Thank you, Dakeem. There is a question regarding calcium being listed as an intervention for postpartum hemorrhage, and what is the evidence of that?
Yeah, thanks for asking. So I just threw that in because there's been some recent data, and I think from our own group here, Jess and Sari, they've been looking at the use of calcium in postpartum hemorrhage with some pretty interesting results. So that's why I put that in as a question mark. I'm not sure whether that is going to become a standard, but certainly the data that Jess presented at one of the combined OB anesthesia meetings was very compelling, that may be a good intervention to decrease the risk of postpartum hemorrhage. So I think that's still in progress right now, but I thought it was very interesting data.
And there is a question in the chat from Dr. Brzezinski. Is there data regarding what percentage of patients with gestational hypertension will develop preeclampsia with severe features if pregnancy continues past 37 weeks? I think you mentioned a 40% incidence.
Yeah. So in the HYPERTAT trial from the Netherlands, 40% of the patients who went beyond 37 weeks developed severe range blood pressures or preeclampsia with severe features. But you can make the argument that 60% didn't. But the recommendation remains for delivery at 37 weeks.
More, we have ongoing questions coming through Q&A, but I think, Dakeem, probably our time is up. And so for folks who we couldn't get to their question, please reach out to Dr. Druzin directly. And I'll just end with a comment from Dr. Christy Coleman. Dr. Druzin, thank you so much for your unwavering support and dedication to all your trainees. You truly inspire. Thank you so much, Dr. Druzin.
Thank you very much, everyone. Have a good day.